All right, folks, so today we're going to be discussing liver cirrhosis and the clinical manifestations, what causes it, and how we treat it. So to start off, you guys really have to understand the functions of the liver to be able to find out what's going on with the clinical manifestations. So to start off, let's discuss liver function once again. The liver functions basically include all these elements: carbohydrate metabolism, protein metabolism, detoxification, and that is aided by the Kupffer cells. Steroid metabolism, bile production and excretion, which happens through the gallbladder and through the bile, we excrete it out. It's actually what gives our stool its pigment of brown color. And then vitamin and mineral storage, among many other things. So we want to make sure that you guys understand that carbohydrate metabolism, protein metabolism, it occurs because of the hepatic portal vein, which is the largest vein that enters the liver. And it's receiving blood from the entire GI tract, from the esophagus all the way down to the intestines, all the way down to the rectum. So every time we consume foods and we break them down, we discussed the digestive enzymes that the pancreas secretes last time, which are amylase, trypsin, lipase. As our blood system absorbs those elements, it sends them to the liver, and the liver can then take your carbohydrates and break them down into glucose and store them as glycogen. And then the liver can also receive the amino acids and start manufacturing or synthesizing other proteins. And keep in mind that the two major proteins that we have are going to be your albumin and your globulin. Okay? And these two proteins are really important. Albumin maintains what we call oncotic pressure, which regulates or keeps in check the fluid in your respective compartments, meaning we're not walking around with edema all day, because albumin keeps the fluid in check. And then globulin is a primary component of your immunoglobulins. The liver is responsible for creating factors that allow your immunoglobulins to be produced, to be carried out throughout the system so they can fight off various types of infections. Detoxification occurs via the Kupffer cells, and these are the cells that take in any type of bacteria that we've consumed in our diet, and it passes it through the liver, and we detoxify the liver in that fashion. But we also detoxify a variety of other metabolites, whether it's drug metabolites, whether it's nutrition metabolites, or whether it's bacterial metabolites. Any elements that are toxic to the system, the liver is responsible for detoxifying it. We also talked about steroid metabolism, bile production. Now, bile is very interesting because bile is where we excrete something called bilirubin. And bilirubin, as I forgot to mention real quick, when our Kupffer cells are breaking down the waste products, it's also breaking down worn out red blood cells, worn out white blood cells, etc. And the byproduct of RBC breakdown, of lysis, is the excretion of something called bilirubin. Now, this is important because bilirubin has a yellow pigment to it, as I mentioned before in previous videos. And our liver's responsibility is to get that bilirubin after it's broken down the RBCs and excrete it via the bile. And that's how we get rid of it in our stool as well. So when somebody has liver issues, this is why sometimes they develop jaundice, because they cannot excrete the bilirubin. It builds up in the bloodstream, and now we develop jaundice. So that ties in with the whole bile production, bile excretion. Remember that the liver creates bile, but the gallbladder stores it, and then it excretes it. And then vitamin and mineral storage as well, such as vitamin K, which deals with clotting. So keep in mind that your liver is also very crucial for the clotting factors production, which allows us to carry out the clotting cascade so we can clot. So what I need you guys to understand is to start to draw a picture as to what the liver does, because that's going to tie in when we discuss when the liver starts failing and what clinical manifestations we're going to be expecting. Now, when it comes to liver cirrhosis, folks, there's 4 basic types. There's Linnaeus cirrhosis, which is drinking too much alcohol. Cardiac cirrhosis, meaning that the cardiac issue is causing the liver to become expanded, or hepatomegaly, like in heart failure. Your blood backs up into the liver, it gets bigger, and then the cells within the tissues, they become destroyed because of the excessive pressure that the blood's carrying, and it starts destroying the tissues. So the liver can no longer carry out its function eventually. We have post-necrotic, and we have biliary liver cirrhosis as well. This is just talking about the etiological factors. What can cause the cirrhosis? Keep in mind that when it comes to cirrhosis, You have at first the liver becomes fatty, so you develop a fatty cirrhosis, inflammation. Then you start developing some scar tissue. The scar tissue is what replaces the healthy tissue once certain damage occurs to the liver and you develop the scar tissue. So think of it like as being scabs in replacement of the hepatocytes, the Kupffer cells, and all the different tissues that are supposed to carry out the metabolic processes for the liver. They start to die off, scar tissue, and eventually when the scar tissue starts growing throughout the entire liver, well, now you don't have enough of those cells, enough of those structures to maintain homeostasis, and that's how you develop the whole scarring of the tissue, the whole liver cirrhosis, okay? And eventually you have end-stage liver disease, and now your liver cannot carry out these functions, and you will eventually die, okay? So let's start off talking about the clinical manifestations, okay? Basic signs and symptoms of liver cirrhosis. When somebody has a liver that's damaged, they develop jaundice. We discussed you develop jaundice because of the excessive bilirubin that's building up in the bloodstream. Okay, so we knocked that one out. People that have liver cirrhosis, they have a high risk of developing infections. Now, why would that be? Well, if the liver is responsible for creating globulin, which is a factor that's required for your white blood cells, for your antibodies, to create, or white blood cells, to create these immunoglobulins, because of course it's your B cells from your immune system that carry out this function. However, it utilizes the globulin so it can pair up the white blood cells, the antibodies, so they can become these powerful sources to fight off any type of pathogenic organisms. So you're going to be at risk for infections. Now, albumin is really important because albumin maintains what we call oncotic pressure. And I have a little way to memorize this. So we have something called oncotic pressure, okay? And oncotic pressure is the way that our albumin keeps our fluids in the respective compartments, okay? This oncotic pressure that we're talking about, right? So essentially we have fluid inside the intracellular compartments, meaning inside the cells. We have fluid, and by the way, we have the most abundancy of fluid in the intracellular compartments, okay? Then we have some fluid in the intravascular compartments. We're talking about the blood vessels and the fluid that's found inside. And then we have the interstitial compartments, meaning the fluid that's found in between the cells. So all in here and all out here, okay? It's the location where we have the least amount of fluid. So keep in mind that your albumin, it keeps this relationship, meaning it keeps the fluid in their respective compartments, and each of these compartments has a normal percentage of fluid in a healthy individual, meaning we don't walk around with edema. We don't walk around with periorbital edema or dependent edema or any fluid that's accumulating outside of their respective compartments in their therapeutic values. We don't have that if you're healthy. However, if you have liver cirrhosis, eventually, when you can't create albumin anymore, you lose the ability to keep the fluid in their respective compartments, and then they spill out. So the way that I teach my students is the relationship between your protein, which is albumin, and H2O, okay, which is water, is the same relationship that a pimp has with his harlot, okay? So, a harlot's a prostitute, for those of us that don't know. So, what's the relationship between the pimp and the harlot? The pimp tells a harlot, like, you can go down Park Avenue, you can go down 12th Street, but you gotta stay clear away from San Francisco because it's a residential area, right? So the pimp keeps the harlot in check. The P for pimp keeps the H for harlot in check. Please don't confuse this with power of hydrogen, pH, that's something else. So what I'm trying to get at is that the pimp keeps the harlot in check. He tells her where to go, he keeps her in line, but what happens to the harlot when the pimp gets arrested or shot or something and they're no longer around to do his job? Well, the harlot's freed finally and she can finally go everywhere, okay? Well, that's the same relationship between your protein and your H2O in your system. If the protein is there, it keeps the fluid in its respective compartment. But if you have liver cirrhosis, where you're not manufacturing albumin, and your albumin falls below its therapeutic value, which, by the way, albumin should be, let me write this right here. Albumin should be anywhere from 3.5 to 5.0, just like potassium. And your globulin should be anywhere from 2 to 3.5. Notice that there is a relationship. It's like 2 to 3.5, and it starts again at 3.5 to 5.0. And your total should be, when you kind of add those up, and should be anywhere from like 6 to 8.5. So just keep in mind, folks, that those are your therapeutic values for the proteins. Now back to explaining oncotic pressure. So when you have a condition where your liver is not functioning well, such as liver cirrhosis, and it's no longer creating its protein, its albumin, well, the protein's gone and the water now goes everywhere. And that's where we get things, signs and symptoms that are included in liver cirrhosis, like ascites. And let me erase some of this stuff so I can make more room. So now that we understand that when you lose your P, your PIMPs, your hardly goes everywhere, your H hardly goes everywhere. Well, when you lose your proteins, specifically albumin, your H2O, the plasma, the fluid in the system, it goes everywhere. And that's what gives us our signs and symptoms of ascites. Also included with the fact that you're going to have increased portal hypertension, and I'm going to write that down right here, increased portal hypertension. But the fact that we don't have the albumin anymore to keep the fluid in check, the fluid spills out of the vascular system into the interstitial compartments, or in this case, the abdominal cavity, and you develop ascites. People with liver cirrhosis, they also end up developing issues with fluid going in other spaces, okay? They also develop edema throughout the system, and that's all caused because of the lack of creating the normal amount of your albumin, your proteins, okay? So keep those things in mind. People that have liver cirrhosis, we can continue with the clinical manifestations, and we discuss detoxification. Well, what does the liver detoxify? Elements from your dietary intake, right? We have proteins that we consume, but you have to understand, as proteins are being broken down to their basic properties of amino acids, well, we have some waste that's given off, and that waste is urea, nitrogenous waste, nitrogen. You guys remember ammonia, okay? So your liver is responsible for breaking down these elements and converting them into their lesser, the smaller size elements so the kidneys can excrete them. But if you have liver cirrhosis, you're not detoxifying the bloodstream from that particular waste, so your ammonia stays the same, it starts increasing, and it also develops toxicity, which can contribute to something called, excuse me guys, Hepatic Encephalopathy. Okay, this is when the toxins in your blood accumulate to the point that your nerve cells, your neurons, they can't communicate with each other well, and you develop a diseased brain, hepatic encephalopathy. Okay, folks, and this can contribute to something called Ascites, which is a flapping tremor, because your brain, your nervous system, is having a difficult time communicating with the rest of your body as well. The patient's level of consciousness is going to be changing because you have all these toxins in the system, in the bloodstream. People with liver cirrhosis also develop basic elements like nausea, vomiting, because the fluid, the blood that's going to the liver, which is supposed to undergo all these particular processes and then come out the other side and go back into the systemic circulation via the inferior vena cava, well, that's not happening right now. And so the blood right here, since it can't go through, it starts backing up, and it backs up at the esophagus, which causes your esophageal varices. And the esophageal varices are very dangerous because the patient may have all these veins in their esophagus that are dilated because of the blood that's backing up from here, from the hepatic portal vein. Eventually the pressure backs it right back up to the esophageal veins, which we call esophageal varices, that they're dilated. And this can potentiate rupturing. And if you have a ruptured esophageal varices, the patient can bleed out and die. So this is all stemming from the basic premise that the liver is no longer able to carry out its job. It's no longer being able to pass blood through, so it starts backing up. People with liver cirrhosis also develop dyspepsia and just basic GI issues because it's backing up into that specific system. Now, let me erase some of this stuff real quick. Now, people with liver cirrhosis, they develop jaundice because the bilirubin level starts increasing. The bilirubin starts increasing because the liver is no longer able to create bile in where it's going to be dumping its bilirubin into so we can excrete it. So the patient develops icterus, jaundice, okay? And this is when you understand the liver is experiencing an exacerbation, an acute complication of its inability to excrete bile and a lot of other potential, a lot of other issues as well. Continuing with the storage of vitamins, I want to really focus on the issue of vitamin K. Vitamin K helps us clot, okay? It's an integral part of the ability to create clotting factors, and it's responsible for initiating or contributing to the clotting cascade, which helps us clot. Well, if you have liver cirrhosis, are you able to synthesize, store, and utilize vitamin K? You're not. So patients with liver cirrhosis will also have a lot of hemorrhage issues. They're going to be bleeding out. They're going to have spider angiomas. They're going to have gingival bleeding. They're going to have to be careful and make sure that the patient doesn't have any type of bleeding, including in the GI tract. You have to assess for melena. You have to assess for black tarry stools, which indicate an upper GI bleed, because the blood has now been digested as it leaves the stomach or the upper GI part, and you're defecating black tarry stools. Melena. You must be giving medications that prevent gastric ulcers, because you understand that the body's under excessive pressure now, and the patient may develop GI bleeds because of the ulcers. So this all stems from your understanding that the patient's going to be at risk for all these things. And now we're talking about just the bleeding part because of the vitamin K issues. Continuing with the topics at hand, I want to discuss how we treat the most common issues that the patient is going to be developing. So let's start talking about some medications first. Lactolose is a medication that's given as a laxative. And what lactolose does is it excretes the ammonia. We poop it out, okay? And that's what ends up happening with when you have somebody that has liver cirrhosis. If they have excessive ammonia levels, if they have hepatic encephalopathy, then we go ahead and give lactulose or neomycin because they help with the excretion of the excessive ammonia levels, and then they go down, okay? Now, people that have hepatic portal hypertension, they have a problem with the blood backing up into the esophagus, and they have potential bleeding issues. So we give medications like vasopressin, propranolol, and octreotide because these medications, they decrease the pressure inside the liver. That's what the medications do. By affecting blood vessels elsewhere, they decrease the hepatic portal hypertension. And that's what we want right now. Because if you're decreasing the hepatic portal hypertension, so we're decreasing it, well, now we don't have to be so concerned with the esophageal varices rupturing and causing a whole host of hemorrhagic issues like hypovolemic shock. And that's the whole reason why we give medications like vasopressin, propranolol, octreotide. So keep that in mind, folks. These medications are very important, okay, for that purpose. Now, some of the complications that you guys have to be familiar with as well is what happens, not what happens, but essentially how do we fix or how do we provide other means of aiding in the prevention of the rupturing of the esophageal varices? Well, then there's a special tube, and this tube goes outside from outside the body. It goes inside the esophagus, and it enters the esophagus. And this is called the Sang-Stankin-Blankmore tube. And this tube kind of looks like this. It goes like this, and it has a little end where it becomes inflated. And what we do is we place this little device inside the esophagus, okay? It's only entering the esophagus, so the patient's still able to breathe. And what we do is we inflate it, and that inflation causes pressure on the esophageal walls, and it compresses the esophageal varices by shunting blood out of that particular vessel, and it decreases the likelihood of the blood vessels rupturing. So that's one way that we can also aid with the prevention of esophageal varices rupturing. The Sang-Stankin-Blankmore tube. Well, I apologize if I didn't pronounce it how you guys are accustomed to it, but that's how I pronounce it. Continuing with the esophageal varices, folks, you have to be looking out for potential indications of bleeding. So we're talking about the monitoring of vital signs, the monitoring of your level of consciousness, and also any type of restlessness usually indicates some type of hemorrhaging in these particular scenarios. So keep in mind, you assess for those things, folks. Okay. There's another thing we can do with the esophageal varices. You can put a scope inside, and the scope will have a little device where you can perform sclerotherapy, where you inject the substance into the esophageal varices, and it helps wither away and atrophy the blood that's in there. And so like that, we remove the blood vessels that can potentially rupture. But that's not a specific intervention for the esophageal varices. That's for any type of varicose veins. So keep that in mind. We do sclerotherapy. Okay, folks? Continuing with other conditions. Or other elements that may be encountered when people have liver cirrhosis. Okay? People that have liver cirrhosis are going to be told, they're going to be educated to decrease elements that can toxify or increase the intoxication of the liver. So what we want to do is we want to avoid medications that are considered hepatotoxic. So we're talking about acetaminophen, amoxicillin, diclofenac, amiodarone, allopurinol, anticonvulsive medication also, okay? Like dilantin, that medication is hepatotoxic. We don't want to give patients any of those drugs because it's going to potentiate an exacerbation in the cirrhosis of the liver. You also want to be careful with not giving isoniazid, INH. This is a medication that we give for the treatment of tuberculosis. And that specific medication is hepatotoxic. And then we have the last one, azathioprin. And this is another medication that's hepatotoxic. So just keep in mind, folks, memorize these drugs, considered hepatotoxic, and these are the drugs that we're going to be avoiding so the patient won't have any more issues with the liver. Okay? I want to focus on ascites real quick. When people have ascites, essentially this is the abdomen, and the abdomen becomes very distended. Remember, the fluid leaves the vascular part of the hepatic portal vein, and the plasma fills in the abdominal cavity, and you develop ascites. Well, what we do to fix this is something called a paracentesis. And keep in mind, the paracentesis is when we put a little port that has a needle inside, and we extract the fluid, and we can fill up this little container with all the fluid that's inside. Okay, that's how we usually treat this. This is considered part of your output, by the way, when it comes to your eyes and nose. A paracentesis is important. You have to remember to empty the bladder. Before you actually insert the needle, because if the bladder is distended, we run the risk of puncturing the bladder that's full of urine, and now you're going to develop peritonitis, which is another potential complication of this procedure when it comes to paracentesis. Okay, remember, paracentesis is the removal of the fluid that's been accumulating in the abdominal cavity. All right, and so continuing the whole assessment part, we didn't really discuss too much on that. We want to look at the liver enzymes, folks. The liver enzymes give us a lot of detail in regards to the liver function. So we have to look at your alkaline phosphatase, your LAP, your ALP. You have to look at your alkaline transaminase, ALT, your aspartate transminase, AST, and then your gamma glutamyl transferase, your GGT. These liver enzymes are going to be elevated when somebody has liver cirrhosis. So just keep in mind to monitor those values as well. Okay, keep in mind, folks, that daily weights are very important for these patients because we can monitor the fluid volume status by assessing daily weights. When we do it early in the morning, we want to go ahead and do it with the same clothes on so there's no discrepancies, and usually at the same time. And I used to be a CNA. When I worked night shift, we had to do the weights like at 5 or 6 a.m. every time when the patient was being monitored for fluid volume issues. Okay, guys? So that summarizes liver cirrhosis. I hope that helped out, folks. Please follow me on, subscribe to my channel, and please follow me on social media at NCLEX Solved. Thank you. I'm sorry, at Learn NCLEX Now. Thank you.